everybody. Okay, so normal bone function. What we need to know, like everything else in our body, is that bone is a living tissue. Absolutely. And what it is made up out of is this two main parts of bone. We have the outer hard compact bone, and then there's an inner spongy bone. So the outer layer is like a shell, if you will, and on the inside is this sort of lattice work, wholly sort of spongy bone. And it's very, very strong, of course. It's made up of a lot of proteins, vitamins, and minerals, particularly calcium. What does bone do for us? Well, it supports our bodies. So certainly it holds us upright. So it helps with our posture. It helps to protect our organs. So if you think of your rib cage and where that's situated and what's inside of it, and if you think of your pelvis, where that's situated and what's inside of it, those bony areas house really important organs. So it helps to protect our vital organs. And as I mentioned before, it's also a bit of a storage bank, or what we call a calcium bank. So a lot of the calcium, 99% of the calcium in the body resides in our bones as calcium salts. And it's what makes our bones so, so strong. Now, growth hormones and many other hormones, particularly sex hormones, estrogen and testosterone, help stimulate both the bone remodeling and bone forming, or reabsorbing and forming cells. And this throughout our lives remains somewhat stable. So there's always this give and take, as you can see down here. There's always a give and take of resorption and deposition. So cells, bone cells, like any other cell in our body, like skin cells, will go through a process of maturity. They'll be laid down, they'll harden, and then they'll also need to be cleared to let new bone grow. And it's in a constant homeostasis or balance. This is what keeps it nice and strong. Okay, but then what happens? What happens when that doesn't stay homeostasis? What happens with osteoporosis? Well, bones become thinner and weaker. They become less dense. And so I think the picture here really shows you this. So here would be the healthy bone with that thick outside compact bone. On the inside, we have the spongy bone. And over time, the bone becomes thinner, it becomes weaker, less dense. And so it kind of almost looks like a crunchy bar, like a chocolate crunchy bar, if you will. The inner part, particularly the inner part, becomes more holey or more spongy. And when it does this, it becomes more fragile. The bones become brittle and they break more easily. Now, any bone can be affected, okay? And we often call osteoporosis a silent disease. And the reason for this is because there's really no signs or symptoms until, unfortunately, a fracture occurs. Now, there is, before osteoporosis, there is a time where we could have what's called osteopenia, and this is the stage before osteoporosis. Now, in saying that, as we age, it's normal to have a percentage of bone loss, just like it's normal to have muscle loss in terms of strength and mass, just like it's normal to get gray hair and wrinkles. There is this sort of spectrum where it is normal to have these losses over time. But of course, if we're starting to err on the side of osteopenia and osteoporosis, this is where intervention really helps. And this is where this presentation will help you learn about what it is and how you may manage it and sort of reduce how quickly or how severely you develop osteoporosis. So then what causes osteoporosis? Well, first, there can be a failure to develop a strong skeleton. So this is something that happens actually as we grow, from when we're born, and we grow. And we actually develop we should be developing a strong skeleton from babies growing into teenagers into our early 20s. So being active, eating well, and getting enough sunshine will help us develop a strong skeleton. But there can be factors and circumstances where this may not be the case. Genetics can have a play. Nutrition can have a play. Perhaps we didn't get the right nutrition as we were growing. Maybe we lacked calcium or vitamin D, for example. And of course, lifestyle. Perhaps we weren't in a situation, or we didn't know enough, or we didn't know that actually exercising, using our body weight to do certain things was important to help stimulate growth. Another one is loss of bone to excessive breakdown, so resorption. Again, this could be due to nutrition. So we could be lacking in vitamin D or calcium. And if you recall, I said our bone was a calcium bank. Okay, so a lot of calcium salts are stored or make up bone. And when we are lacking in calcium, for example, the body will leach calcium from our bone. Now, a little bit of that once or twice might be okay, but imagine the compounding effect if that's happening over years and years. Another factor could be medications that we're taking. So excessive breakdown of bone or the leaching of calcium can happen due to medications like corticosteroids, for example. That's a common cause of bone disease. But sometimes we can't help that, but it's certainly a factor. And also long-term inflammation can also lead to loss of bone through excessive breakdown. Now, in combination with excessive breakdown, you may also have failure to replace lost bone. Now, replacing bone is stimulated by hormones, many different hormones, particularly growth factors, and again, those sex hormones, estrogen and testosterone. So sometimes they can be affected. And some of you might already be thinking, particularly for women, there's a particular time in a woman's life, quite significant, where she loses a lot of her estrogen or all of her estrogen, and this would be menopause. So when we're taking away those hormones that help replace the bone, you can see how osteopenia and osteoporosis starts to occur, because the scales are tipping. We're reabsorbing more bone or more calcium than we're actually laying down. So not only is it loss of or interruption of hormones, general age as well. So just a general reduction of replenishing bone cells due to age, and just general loss of systemic and local growth factors. Then the last one here is an increased tendency to fall. So particularly as we age, if we have excessive falls, this can have a negative impact on our bone and bone health. We could also have loss of muscle strength, slow reflexes, and poor vision. And again, long-term drug use that help, or should I say, doesn't help the bone to repair. So all of these sorts of things can cause bone loss. So who gets osteoporosis? Well, both women and men get osteoporosis. And as you can see here, this is more following, I guess, a woman's lifespan, because they are the most significantly and severely affected by osteoporosis. But we all, as we age, we all have this active bone growth, and we reach peak bone mass around 20, anywhere between 25 and 30. And we maintain this for a little while. But then, like I mentioned before, as the aging process occurs, normal loss happens. But then again, there are all those other compounding factors. For example, the medications that we may have used. We could have had falls, for example. Nutrition could have been lacking early on, okay? But basically, what we're trying to show you here is the rapid loss come menopause. And that's because we lose estrogen. And remember, estrogen is a hormone that helps stimulate bone growth. And just to show you in a different way is this other graph here. And this one here depicts both women and men and the difference between bone increase, okay? And we get this peak bone mass just around here, okay? And what's the difference here? You can see already. Men generally are larger, their structure skeletally than women. So they generally have more bone mass anyway. So they've got more to lose before it actually affects them. So if you will, comparatively, we don't, as women, we don't reach the same amount of bone density than men do. But we maintain this throughout our life. And then as we're aging, 45, 50, 55, we have a steep decline. Now, men, it takes a little bit longer. Why? Because they don't have a rapid, significant loss of their driving sex hormone being testosterone. It peters off slowly. There will come a time at around 75, where they're more susceptible for OP, osteoporosis. But versus women, this will happen a little earlier. And as you can see, a lot more significant and severe. So that's sort of the differences there between the two. But at some point, both men and women will be susceptible to osteoporosis due to the lack of testosterone and estrogen. Okay, so are you at risk? So what we have is two categories. We've got modifiable risk factors and non-modifiable risk factors. And the modifiable risk factors are the ones that we're going to kind of be focusing on today, because they're the ones that we can change. Now, we don't have a time machine that we can go back in time, unfortunately, but we can change these things now. We can start working on them. So I'll briefly look at these ones, and then we can talk about the non-modifiable risk factors. So we can certainly make adjustments to our diet when it comes to calcium intake. And we're going to talk, well, actually, Jess is going to talk more about this in a little while. Vitamin D, we can make changes to the vitamin D that we get or we synthesize by making small changes and getting out in the sun at certain times. Low levels of physical activity, well, again, that's an easy change as well. We can start to slowly, progressively increase exercise. Smoking, we should be reducing or ceasing. Excessive alcohol intake, again, the same with the smoking. It's one of those factors that significantly impacts systemically our health, but also our bone density. So reducing those smoking and alcohol can help stop the loss of bone, the rapid loss of bone as we age. And also, again, with our weight. So sometimes having a low body weight or excessive weight as well can impact our bone health. So trying to find a healthy weight range. And then there are the non-modifiable risk factors. So in terms of our age, well, we can't help our age. The older that we get, the more susceptible and at risk we are of developing osteopenia and osteoporosis. Unfortunately, being female with female reproductive organs, we can't necessarily change this unless there are significant surgical interventions. You may have had a family history of osteoporosis. Again, this is that hereditary genetic factor that comes in. Unfortunately, the long-term use of medications like steroids, we can't change, but perhaps we could modify. We could maybe ask our doctor to revise things. We've got hormone levels, thyroid conditions, and chronic health conditions causing inflammation or malabsorption. So I'm talking about the GI tract here, particularly if you've had GI surgery. And for example, celiacs, whose stomachs and intestines can be quite sensitive to different foods. If the lining of those walls in a GI tract are disturbed, the absorption rate of calcium and vitamin D and other minerals that are needed can be significantly affected. And that is then passed on to our bone health. So because we can't really change a lot of those non-modifiable risk factors, we're going to be focusing on the modifiable risk factors come the back half of this session. So I want you to have a little think now. While most of you in this session this morning said that you do have osteoporosis, for those people who are not sure and don't, I want you to ask yourself these questions. So are you at risk? Do any of this list apply to you? And if the answer is yes, you may need to consider making an appointment and talking to your healthcare provider. So ask yourself, is there a family history? Falls, like a broken hip? Has it been in the family? Have you had a broken hip before or broken bone? A celiac disease or any GI upset or other condition, which would add to the malabsorption. Do you have rheumatoid arthritis or some other inflammatory arthritis condition? Because remember, long-term inflammation of the body or systemic inflammation can also significantly affect our bone health. Have you been taking steroids for longer than 3 months? Have you gone through early menopause? Men can suffer low testosterone levels as well. So if that's you, you may consider talking to your GP. I'm sorry. May we please put our mics on mute? Just getting a bit of feedback there. Overactive thyroid or parathyroid conditions. You would know this. You'd already be treating this. Treatment for breast cancer or prostate cancer. And if you've noticed a loss in height, 3 centimeters or more, and often that's the case in the spine. So the vertebral bodies in our spine that stack up on top of each other, the body itself, if you're getting osteoporosis or osteopenia in here, these can start to shrink and we start to sort of get a bit hunched over and we're losing height. So if you've been noticing that, again, perhaps it's time to go and have this conversation with your GP. So very quickly, if you don't know, how is it diagnosed? Well, we've sort of spoken about medical and family history. Your risk factors will be considered. Has there been a loss of height? Sometimes, and very often I hear from the community and clients in the past that the first time they knew that they had osteoporosis was because they had a fracture. They fell over, they bumped their arm, or they broke something. Usually it's wrist because they've fallen over and they've put their hand out. Wrist, forearm is most common, and hip. And then they've had an x-ray. Yes, you've got a fracture there, and potentially because of age, potentially because of sex, being female, they've gone ahead and done a DEXA scan, which is a bone mineral density test. And at that point there, that's when they found out that they have osteoporosis or osteopenia. Okay, so that would be the next step then, is to get that tested through a DEXA scan, and essentially mostly scans your spine, your hip, the long bones of your femur, so that your thigh bones. It can scan all your body essentially, because osteoporosis can happen in all of the bones. And in this case here, you will get an outcome. Now, there is a heel ultrasound test, but it's not the recommended standard test because it isn't as reliable or as accurate as a DEXA scan. So DEXA scan is the gold standard test. Now, the DEXA scan does attract a Medicare rebate at certain levels. So I think it's over the age of 70, you can get a free DEXA scan. And of course, if there are conditions that you already have, if you're on particular medication that all lead to or increased bone loss, you may be able to get a free or subsidized DEXA scan. And they're often done 12 or 24, so between 1 and 2 years apart. And again, it really just depends on your circumstance in terms of maybe other conditions, health conditions that you may have. It's non-invasive. Often you might be lying like this person is here, or you might strip down and wear a gown, but it's certainly non-invasive. You just lie down. It takes a few minutes and away you go. Now, in terms of the DEXA outcome, you'll be given what's called a T-score. Now, a T-score here If you get a T-score between 1 and -1, this is what you would call a normal result for that age group or that population. So you've got normal bones for your age. So keep up, do what you're doing, ensure you've got adequate calcium, vitamin D, you're doing regular exercises. Now, if you get a DEXA score of -1 to -2.5, you are at risk of developing osteoporosis, and the fracture risk is low to medium. You will be placed in the category of having osteopenia. You should take immediate action to minimize further bone loss. And again, you'll work with your doctor or a dietitian and come up with a plan to ensure if you are deficient or lacking in calcium, vitamin D, to ensure that you are receiving that. Sometimes it's an aggressive treatment to get you back up to a level or standard in terms of enough calcium, enough vitamin D, and we just do this through blood tests. And then lastly, you have a DEXA score -2.5 or lower, and this is osteoporosis, and you are at a high risk of fracture. And again, this might require significant and fast-acting intervention with calcium and vitamin D injections. You may even go on a form of some medications to bring you to a level where it's safer, and then you can just manage conservatively from there. Okay, now we're going to talk about the 3 pillars of bone health. This is the modifiable stuff. This is the things that we can look at, take in, and potentially change and adjust. So we're going to look at adequate calcium, adequate vitamin D. We're going to look at regular bone-friendly exercise, and then avoiding negative lifestyle factors. So these are the 3 pillars of bone health, and I'm going to pass over to Jess, who's going to talk about calcium.
Hello, thank you, Kat, for having me here today. I do have a little bit of noise sort of just happening in the background, so hopefully that's not coming through too loudly, but I apologise for that. So as Kat has mentioned, calcium, so there's various different vitamins and minerals that are important in our bone health. But like Kat has explained, one of the main nutrients that's particularly important in helping to protect us from developing osteoporosis is calcium. And this is because, again, as Kat explained, our bones act as a calcium bank. But calcium is also essential for other functions in the body. So in our cardiovascular health and in muscle contractions. And because of these sort of other activities need calcium, it's quite essential for that. If we don't have enough in our diet, what our body does is pulls that out of our bones, and that's where we sort of lose some of that calcium that's stored in our bones. So calcium, our body doesn't make calcium. So all of the calcium that our body needs comes from our diet. And you probably know that dairy foods are a particular source of calcium. But there are some other sort of sources that have smaller amounts of calcium. And of course, these days as well, there's a lot of dairy food alternatives that can be quite good sources of calcium as well. Yeah, that's next slide, Kat. So this slide shows a couple of different things. So you can see the recommended daily intake of calcium. So that's the amounts, that's in milligrams there. And it also shows the recommended serves of calcium-rich foods. So this comes from our national dietary guidelines, and these serves take into consideration the amount that people need each day. So for most of us, we don't need to sort of be specifically counting the milligrams that we're consuming, but making sure that we're eating a variety of rich calcium sources. So what we can see is how calcium requirements change by age and during different life stages. So adequate calcium is important at all stages of life, but it's particularly important during stages of growth. So during childhood and adolescence. Kat also mentioned that we reach our peak bone mass in our 20s. So as we age, we then start to lose some of that bone mass, and that's where calcium also becomes particularly important later in life. And we can also see requirements for women are higher from around the age of 50. And this is because of the hormonal changes that occur around the time of menopause. So another point to make is some people may not be able to get enough calcium from their diet. And in these cases, you may need to take a supplement. So if you're not sure if you are getting enough calcium or you think you might be a bit low in your diet, it's a good idea to speak with your doctor about whether you may benefit from a calcium supplement, and then they can provide advice around the types and the amounts that might be suitable for you. Next slide, please. So this slide provides some examples of calcium-rich foods, as well as some other foods that contain smaller amounts of calcium. So as I mentioned, really some of the main sources are dairy foods, so milks, cheese, but we've also got other foods that can be sources of calcium. So about 100 grams of almonds with skin on is also a serve of calcium food, tofu, and also foods like salmon with the bones in as well. So if you are regularly consuming dairy foods, it's likely that you'll be getting most of your calcium from a few serves of dairy foods a day. So it might be a cup of milk at breakfast time, you might have a tub of yogurt during the day, and maybe some cheese in your lunch. And that's really going to be making up most of your calcium needs for the day. Also, if you're concerned about gaining weight or you're trying to lose weight, low fat or reduced fat varieties of dairy foods are also completely suitable and have about the same amount of calcium in them as well. As I mentioned before, there's also so many alternative options to dairy foods now as well. So things like plant-based milks, yogurts, and cheeses. These foods don't naturally contain calcium, and the way that they get calcium is that they're fortified with calcium in them. So not all varieties will include calcium. So it's a good idea when you're selecting these foods, if you don't have dairy foods and have dairy alternatives instead, just to have a look at the nutrition panel to see if it does have calcium in it. So a good way to sort of compare is having a look for calcium in the nutrition panel and then comparing across the per 100 gram column. It's also a good idea to do for dairy foods as well, because things like, even yogurts can have such variety across the different types of yogurts and how much calcium they have. So having a quick look at the nutrition panel can be quite helpful to sort of have a check which is highest in calcium and which might be a bit low. But it's also important to note that calcium won't appear on all nutrition labels. It's not a requirement to include it. So it generally will usually be on foods that are a good source of calcium. I'm just checking if there's anything else I needed to mention. And again, I think if you're unsure about how to include enough calcium, or you're a bit worried that you're maybe not getting enough in your diet, like I mentioned, having a talk to your doctor or even seeking out the support of a dietitian can be really helpful. A dietitian can sit down with you and have a look through your diet and work out if you are low in any particular nutrients, and then work with you to sort of find foods that are suitable for you and how you can include them in your diet to meet your calcium requirements. And back to you, Kat.
Great. Thank you, Jess. That was very, very informative. And I'm glad that you did mention the whole low fat versus, I guess, full fat type, particularly dairy products, because a question that I get asked often is, well, what if my doctor says I need to up my calcium intake, but I also need to lose weight? And so yes, having those skim or light milks or other dairy products, it often doesn't affect the calcium content, so you should be okay. But like Jess said, just checking or comparing the nutritional panel, looking at calcium across the 100 milligrams side of things, that should help. Thank you very much. Okay, so just as calcium is important to help our bones, so is vitamin D. And vitamin D is so important. And the reason is that calcium cannot be fully absorbed in the smaller intestine without the help of vitamin D. So they go hand in hand. So vitamin D is essential for bone health. It helps to regulate the amount of calcium in the blood. And if it's in the blood, it can be used directly, or it can go off and be stored in our bones. It certainly also helps maintain muscle strength as well. So much like calcium, it's best to get it from natural sources, so from your diet. With vitamin D, it's best to get it from the source itself, and that is sunshine. That is the sun. Now, a lot of people get a little bit standoffish here, and they go, "Oh, but I'm not supposed to go out in the sun. I need to be careful of skin cancers." And I agree with you. So we're going to cover that in a moment. So the main source is sunshine. It's actually the UVB rays, not UVA, which is a very harmful rays. And you can get small amounts of vitamin D in some foods, but once again, we really want to rely on getting sunshine to help synthesize vitamin D. Well, Kat, how much do we need to get? So first of all, to attract as much sunlight as possible to synthesize the amount of vitamin D that we need to show about 15% of our skin. So we're talking, for example, in summer, if you're wearing a short and t-shirt or something like that, it's showing your arms and showing your lower legs, and that's enough. I always get these weird and wonderful comments from people. One weird and wonderful comment that I've got was that you can only absorb vitamin D, from the sun, to synthesize vitamin D through your stomach. So I'm like, okay, so we're either sunbaking, we're in our birthday suit, doing our washing, hanging up our washing on the line. Like, that's not true. It's not just absorbed through your stomach. Perhaps it's a good idea though, because it's a larger surface area, so I understand it. But really, all it is about 15% of the skin exposed to the sun. And it really depends. The time spent in the sun will depend on the season and skin tone. So let's have a little look at that. So for skin type, for moderately fair skin, how long do you need? Well, you only need about 6 to 8 minutes in summer, 25 minutes in winter. And again, you can see the differences between the seasons as well. And obviously in summer, we're closer to the sun, so we need less time. And in winter, we're further away. So you'll need more time in the sun to attract the UVB to synthesize enough vitamin D. So when should you be going out? So in summer, we really want to avoid that peak middle part of the day. Obviously, it's the hottest there, and it's probably the most harmful in terms of UVA. So it's the mid-morning or mid-afternoon. In winter, you can probably afford to get out there at midday. The UVA isn't as harsh at that particular time. When it comes to darker skin, they're more adapt to the sun and the UVA rays, hence the darker pigmentation. So they need a little bit longer in the sun in both summer and winter, as you can see. And in terms of when darker skin people, the appropriate time to get the sun, it's the same. That's essentially the same. But basically the difference being fairer skin, not too well equipped for the sun, don't need as long, and darker skin people need longer in the sun. And a takeaway from this slide is, if your shadow is longer than you are tall, you're not making vitamin D. So just keep that in mind. It may help you to think, oh, when should I be in the sun? Now, I know saying this, going out at midday and those times around, midday 12 can make people feel a little uncomfortable because of the sun and the higher rates of particularly skin cancer in Australia. And funnily enough, Australia, we have some of the highest vitamin D deficiencies going around, and it's likely due to the campaigns and the push in the years ago with the slip slop slap. So what I suggest is getting the sun in, okay, for those amounts of time, the 8 minutes or the 20 minutes, and then go ahead and do your slip, slop, slap, because of course you're creating a barrier when you do the slip, slop, slap. At the same time, you really need to get adequate time in the sun to make vitamin D. So it's a bit of a juggling act yet again. Okay. And one last thing, often you'll find, but because you can test vitamin D levels through blood, right? So your doctor will do some blood tests to see what's going on. It's okay. So what you need to do is have a look at your vitamin D levels over a long period of time, because they will fluctuate. Obviously, in winter, we don't get out as much as we do in summer. So in winter, they're probably going to be lower, but in summer, you'll often make up for that. And it's accumulative over time as well. So it's good to monitor your vitamin D levels over like a year, to look through the seasons to see how it actually is fluctuating and if it really is enough, or you might need supplementation. Okay, the third pillar of bone health is exercise, getting and engaging in regular exercise. It's essential for building and maintaining strong bones. We want to maximize peak bone density and strength. We want to maintain what we have in our 20s and 30s. It slows bone loss, because what exercise does is it prompts the brain to prompt hormones to help make and lay down bone, because we're using it. So the brain says, oh, we need to keep the bone strong because Mary Jane is using it. So it will adapt to how you're using your body. We also, obviously it's essential for maintaining muscle strength. Muscles attach to our bone via tendon. So we want muscles to be pulling on bones, okay? Because that again triggers the same messages in the brain, for the brain to trigger hormonal responses to help create and make bone strong. So we need strong muscles as well. And of course, it will help improve coordination, flexibility, and balance. And if we have that, we reduce falls. And of course, there are a range of other health benefits to maintaining our exercise. So cardiovascular health, just for an example. So what do we do? So first of all, we need to ensure that we're fit and we're ready to start an exercise program if you're not already exercising. So talk to your GP about this. Are there any barriers or contraindications? What can and can't you do? An exercise physiologist or a physio can also help you out in this department. So how much exercise do I do and what do I do? Well, look, exercise as often as you can, for as long as you can on most days. It's also about increasing incidental activity as well. So it's the walking to and from a car or to and from a train station, for example. It's the walking or the activity that you're doing while you're shopping. So they're all really important aspects of keeping physically fit. You want to aim for a variety and a mix of exercises. So weight-bearing exercises. So we've got walking or dancing as an example. We've got muscle strength training. So we've got, this can be you in the gym, but you can also do things at home with TheraBands or even shopping bags and cans of food. We can use them as weights. And we've also got balance and posture exercises as well. So Tai Chi is amazing for this. So is yoga. But what you want to do is start slowly and build gradually. And you can increase the weights if you are using weights, like hand weights or dumbbells, for example. You can increase that weight, but we just want to do that gradually. So you slowly build. It's like having grandkids, for example. So when your grandchild is born, they're a baby, you carry the baby. And then as the baby grows, you're gradually increasing your strength to pick that child up. So that's what we want to do here. So we were looking for osteogenic type exercises. So what you want to engage in is basketball and netball and dancing and gymnastics and impact aerobics. And I hate when I have to say that, because really, I'm not sure how many people are doing those exercises, and maybe they're not appropriate for you. Don't worry, I have some exercises that may be more appropriate to you. But what we're trying to say is that impact exercise is the best to stimulate bone growth. We've got moderately osteogenic exercises. So that's the running, jogging, brisk walking, resistance training, stair climbing, all the way to the other end to the non-osteogenic exercises, which is swimming and cycling. They're great for our cardiovascular fitness, and they're fantastic for those people with arthritis, but we want bone stimulating exercise, and swimming and cycling are kind of non-weight bearing. So they're not the best for bone stimulating, but they're great for people with arthritis when weight bearing is a problem. And if you've got both of those, it's a juggling act for you. So you can be in the gym and you can be lifting weights like these guys. Sometimes the gym is for you. Some people love the gym, but some people don't like the gym. It's not their thing. It never has been. So Kat, what can we do instead? Well, you're probably already doing these things, but now you're going to know about it, be more conscious of it. So gardening is a fantastic way to stay fit, but also you are bending over, you're shoveling, you're walking around, you're carrying things. These are fantastic osteogenic exercises. What about climbing upstairs? Go ahead. Stair climbing is a moderate osteogenic exercise. Go nuts. Carrying our groceries. You are weight bearing and carrying things. Another fantastic way. Do a couple of trips back to and from your car. Getting involved in some sort of social activity, dancing is a fantastic one as well. That's just an example. But basically, at the end of the day, be as active as you can on as many days as you can. Pick something that you like to do, because obviously you'll engage in that more often. Okay. Here we have medication. So I'm going to briefly touch on medications, because there's actually a lot of medications, and I only can briefly touch on it because it's not so in-depthly in my wheelhouse. But medications are essential for the management of osteoporosis, depending on the severity, of course. So medication help reduce further bone loss. It can help gradually increase bone strength over time, and it can help prevent fractures. We have a range of medications in Australia that, of course, that you will need a prescription over the counter from your doctor. And of course, your doctor will determine what and if medication is right for you. So the main medications for osteoporosis is bisphosphonates and denosumab. So both taken differently, but they both slow the rate at which bone is broken down. There's hormone replacement therapy, mainly for women, but men can use it obviously for testosterone, and this helps maintain bone density. And then there is also some pretty hectic medication for bone building medications, and this if you have severe osteoporosis, and often it's taken for a shorter period of time, and once you've built bone back up to a safe level, then you may go on the biphosphonates, for example. What about supplements? Well, Jess touched on this slightly. And I get a lot of questions about shouldn't I take supplements, and should I take calcium and vitamin D together? What's calcium sulfate? It's all these different questions which are best directed at a dietitian, sometimes a doctor, but particularly a dietitian. But from the Royal Australian College of General Practitioners and what they recommend. So calcium and vitamin D shouldn't be used routinely in non-institutionalized elderly people. The benefit of calcium and vitamin D supplements in terms of fracture reduction is actually quite low, because you're better off getting it from your actual diet, getting sun and getting exercise. The evidence of significant benefit in people at risk of deficiency, particularly institutional individuals. So there is evidence to support the use of calcium and vitamin D when there is a deficiency in these, and particularly institutionalized individuals, purely because they're often not getting as much movement as they normally would. They're not getting outside as much as they would, and potentially the nutritional aspects of their diet might be compromised as well in these places. And of course, calcium and vitamin D supplements should be offered to people taking osteoporosis treatments. If their dietary calcium is less than intake, is less than 1,300 milligrams per day. So the RACGP recognizes that we really need to look towards our diet and our lifestyle to get adequate calcium, vitamin D, rather than actually using supplements, unless they're indicated. Can you reverse bone loss? Well, through those medications that I spoke about, yes, you can in some degree. And through supplementation, probably not. So don't think taking calcium and vitamin T is going to reverse the bone loss. If it does anything, it's just going to help support your body maintain what you have. Now, I'm just looking at the time. We've only got about 5 minutes left. So I'm just going to cover a few slides on fractures, only because they go hand in hand. I'm only going to spend a few more minutes here, and we'll finish up at about past. The reason why I include it is because, like I mentioned earlier, most people find out they have osteoporosis when they've had a fall and they sustain a fracture. And then they'll go ahead and have an x-ray and or a DEXA scan, and then they'll find out. So it's important to note the information about falls. 1/3 of all people over 65 years will have a fall every year. And 10-15% of falls result in a fracture, often in the upper arm and wrist area. And that is because, low bone density increases our fracture risk. And sometimes it's what happened first, chicken or egg. Sometimes even the functionality of standing can cause a fracture in the hip and then you fall, or you could be moving and have a fracture in the hip and fall, or is it because you fell, then you sustained a fracture? So either way. But falls are more likely in people with poor leg muscle and strength, poor balance, or poor eyesight. So there are some other risk factors or questions that you can ask yourself. When you get up out of a chair from watching TV or reading a book or sitting at your dining table, do you require significant use of your upper body to push you up? Or do you need to grab something to pull yourself up? If the answer is yes, then you likely have poor leg muscle strength. In terms of balance as well, you could be on medication that causes you to be a little bit dizzy, lightheaded, also inner ear issues. And then of course there's poor sight. So if you're ticking boxes there, it may be time to start doing something about this. And of course, people living with other chronic health conditions are at a higher risk. So these are the common risk factors to falling. We've mentioned a few in terms of physical. So vision, impaired balance, muscle weakness, medications. Another one is poor foot health. As we get older, we often neglect our feet, or they have been neglected throughout our life. We try to squeeze our feet into these small little shoes with pointed ends, and we lose the width of our foot, and that width of the foot provides balance. So poor foot health, and poor nutrition, and again, chronic health conditions. But there are also environmental factors. So hazards in and around the home, outside the home, in our local community. An example could be uneven footpath, for example, or large gutter steps. And again, inappropriate footwear and clothing can also impede us. So dressing gowns, for example, baggy clothes, baggy dresses or pants, and slippers and slides. They're easy to put on, particularly if we can't get down there to tie it up, like shoelaces or whatnot. So I understand it from that point of view, but they don't provide the stability that we need, and they can be a trip hazard. So preventing a fall, we must use our medications correctly, particularly if they need to be timed. So we want to reduce any medication clashes or interactions that might cause us drowsiness, fatigue, or dizziness. So always ensure that you're taking medications as prescribed. Changes in eyesight. We need to have our eyes checked every 2 years. obviously you may already know this, particularly if you already wear glasses. Wear prescription glasses correctly. Take your time getting used to bifocals. They take a bit of a time to get used to, and they are a cause for triple fall hazard. Okay, so take time to adjust, particularly with light changes and at night. Wearing sunglasses to minimize the glare outside as well, so you can see the environment around you and beneath you. Footwear is important. This is the ideal shoe. I know it can be difficult to get down there to either put them on or tie up laces, but we have a shoehorn that can help get your heel into the back. And if you're not doing laces or you can't manage that anymore, we have Velcro straps and other ways and means to ensure that the shoe is on your foot securely. Wearing slippers and slides are easy, but we need to be aware that scuffing around in those can cause a trip hazard. We've already discussed nutrition. There's no difference here with the nutrition that we've already spoken about when it comes to osteoporosis and managing that. It's about calcium-rich foods. It's about getting enough sun to synthesize vitamin D. But the other point here is ensuring that we're eating enough for our energy demands. So if you are a 100-meter sprinter, you're an athlete, you would expect that person to eat a whole lot more than somebody who is not. And the reason why that is because they need to meet their energy demands. So do you. So we don't want to overeat. We may put on weight. We don't want to undereat, so we're weak and or dizzy. So we want to maintain energy for the energy that we expend. Staying hydrated, that is key to reducing falls, because often we're not drinking enough. We'll have a cup of tea and a cup of coffee, but we need to ensure that we have water on top of that as well. Preventing a fall around the house, and I'm almost finished. So keeping an eye out for these sorts of things. Steep stairs, stairs without railings, reaching high, cords, uneven paths, mess on the floor, carpets that flip up. Half of all falls occur in and around the home. If you are concerned about your home, an occupational therapist can come in to assess your home to find the dangers or the fall points, and they can help you work with those and adjust and fix them. So we've mentioned a few of these already in the pictures, but just being aware of stairs, ensure that they're lit well. Halls, you might need a light at night. Cleaning up food spills, liquid spills. Bathroom and kitchen floors, slip resistant. So putting a few mats down that are stuck to the ground, not just carpets that can flip up, like your loose rugs. Ensure that we secure those. There's lots of nifty little things that you can do now, almost similar to double-sided sticky tape, that you can stick them down on the ground and they won't sort of move. Toys and clutter and electrical cords. So we want to ensure we clear those up. And these are just more. So using furniture as a walking aid, so furniture surfing, we want to try and avoid that, because we can lean too much to one way and we can fall, or the furniture is unstable as well. So we can think about installing handrails. We can look at raking up leaves and branches and things like that. So the ground is clear and we can see. So how can you reduce your risk of a fall? So summing that up, staying active, balance and strength exercises, taking medication as prescribed and reviewed regularly, checking your vision, wearing appropriate footwear, eating well, staying hydrated, improving the safety around your house, and being aware of the hazards in your community. In summary, peak bone mass is achieved in your mid to late 20s up to 30s, and then it declines, particularly for menopause around, it depends now, let's say 45, 50, 55 for menopause. And then men a little bit later in their 70s as their testosterone drops. We want to maintain it and minimize the risk of developing osteoporosis by remembering the 3 pillars of bone health: enough calcium, enough vitamin D, and engaging in bone-friendly exercise. Talk to your GP for any risk factors, tests, supplements, or medications. And recognize and consider risks in your home and community to minimize the risk of falls and fractures. Contact us for further information. You've also got a wonderful website in Healthy Bones Australia. So they deal with a lot of osteoporosis resources, and there's a whole heap of fantastic information on their website that you can check out. Okay, that brings us to the end. Again, I apologize. We've gone over just 4 minutes. I can't help myself. I'm very sorry. It is a long one, particularly with the falls prevention at the end. But if you have to go, you're more than welcome to go. Not a problem. But if anybody has any questions they'd like to ask, you're welcome to pop it in the chat box now. Or if you would like to unmute yourself, you can ask a question and I'll do my best to answer you. Speak now or forever hold your peace.
Kat, I understand bisphosphonates reduce the bone loss and they also increase chemically the bone density. My understanding is that it's obviously not the same as having your original bone, and in fact the remodeling of that bone through at least biphosphonates, I'm not sure about any of the other medications, actually make your bone regrowth more brittle, so that there's a sweet spot in terms of how much remodeling through chemical means you can have.
Yeah, you're right. Absolutely. I think you summed that up nicely with that sweet spot. Yes, doing it through chemical means or the medication itself will get you to the point of safety or increase the safety or the strength of the bone, but only so much. There are other significant side effects of biphosphonates and others as well, but that's why it needs to be regularly monitored by your GP. Yeah, that's a good point. Thank you for pointing that out. Any other questions?
Since nobody else is asking anything, I think it's slide 17, you said the benefit of calcium and vitamin D supplements for risk fracture reduction was low.
Yeah.
Why would you bother taking them then? Because that would be the main reason that you would take particularly those two in conjunction with each other.
Yeah, look, a lot of research has been coming out and it has been for a long time. So I guess the key message here is if you have a deficiency, then it's indicated to take. If you don't, then it's unnecessary. You might actually be erring. Here we go, Jess, about pH. So I can't go into it too much, but we can overtake or take too much of these supplementations as well, which then can have a negative effect at that bone loss or net level. So yes, logically it makes sense. If I'm losing calcium or don't have enough, if I don't have enough vitamin D, then I should supplement it. But what we want to do before we do that is try to manage that conservatively and do it through diet and getting enough sunlight first. That would be what we would say. There's also been a few things come out lately that taking calcium. Now, I don't know, so I shouldn't say it, but there was something about the hardening of arteries, but I'm not sure.
Yes. You're right. There was some concern about taking calcium. And the other thing that I'd mention, I don't think you touched on it, was that there's not much point having a calcium blood test, because if the blood needs it, it takes it from the bone anyway. So it's always going to be quite okay, your blood calcium levels.
Yeah, look, of course, there's always a parameters. There's an upper and lower parameters. And it's something that will probably need to be looked at over a few assessments. But with that, the doctor will always also look at, oh, you're a female. Oh, you've been through cause. And so then they'll need to investigate further. And that's where your DEXA scan comes into play and those sorts of things. But that's a very good point. Thank you, Leslie. Yep.
I have
a question too.
Is that Nicole? Yes.
Yeah. Hi. I suffer from inflammation, and you mentioned that long-term inflammation can lead to bone breakdown. How does that work? What do I need to do about that?
Generally speaking, there's potentially, off the top of my head here, there are two ways. Depending on the condition that you have, it may be treated with a steroid or corticosteroid. Steroids, in the end, long-term use of steroids will leach calcium from your bone. Okay, that's the number one. Number two, your body is constantly in a fight or flight or, kind of situation. There's increased antibodies, there's increased inflammation. And again, that changes pH levels in our body. And if that's the change, the body needs to maintain a homeostasis with pH in our blood. And again, it will leach calcium from our bone. So they're two main reasons why. There's probably many others.
Okay. Thank you.
Can I have a question to ask regarding, I've got the Cancer Council SunSmart app.
Yes.
And what level of UV below is useless for me to sit out in the sun? Because I'm on medication where it says don't go out in the sun.
Don't go out in the sun. Yeah, that's a really good question. And actually, you asking that has reminded me of something. Now, I can't answer your question in full, I'm sorry, because of the other complications that you may have with other medications. So, for example, I was on Roaccutane for a little while, and I could not go out in the sun. So I could imagine that my vitamin D might have been affected as well. So I understand, but I'm sorry, I can't answer that question.
That's all right. Does the research say for a normal person below what level of UV rating?
So well, not that I have read, but it's not the UVA that you need. I already said that, but it's a UVB. So another point on that is you need to get direct sunlight. So sitting in a sunroom thinking that you're all nice and cozy, getting that warmth on you, you're actually blocking UVB. So you need to get direct. Well, I know that one. Jess, do you know the answer to this one at all?
Yeah, I don't know. I don't have anything
okay.
else to add.
No, that's
just
a really good question.
Yeah, because you've got the SunSmart app, and I'm trying to work with it
out. Yeah.
To like, when do I do my outdoor exercise and all that sort of stuff?
Yeah, coupling it with exercise. What a great way to do that. So, best UVB for vitamin D. Let's have a look. Oh, here we go. It's a fairly reputable website. UVB wavelengths. I'm just popping it in here.
Yeah.
Between 290 and 315. That means nothing to me, but it might mean something to somebody else. Yeah. 315 is the main source for producing vitamin D in the skin and is the primary source of vitamin D for the body. There you go. So I'll pop, there you go. That's what. Yeah. So there you go. That's we all learned something today. Look, it's in a study. It has to be good. It has to be, the National Library of Medicine. Look, it has to be real, doesn't it?
Yeah.
Mm-hmm.
It has to be reputable.
I'll ask the endocrinologist that.
That's a good question. Yeah, that'd be great. These are really good statements, comments, and questions, guys. Thank you so much. We do our best to answer them. And if you have any further questions, you can always email me and I can do a little bit of further research for you. But thank you so much for staying on. We've taken up a lot of your time, I know. But I hope you enjoyed the session. There is a survey that will come out. Apologies, it hasn't been changed. Some of you are from Queensland, I know that, so please ignore where you're from. You can put your postcode in, just ignore where you're from. But feedback is great. It helps inform changes on our end. Okay,
thank you.
So enjoy, get some sun, some calcium, and get some exercise, and we'll see you next time.
Thank you.
Thank you very much.
Bye.
Later. Yes,
Bye-bye.
you're welcome to stay on if you like. Oh, no, she's gone.